Welcome to the Deep Dive. Today we are taking on a challenge that sits right at the intersection of, well, high clinical intensity and just fundamental human biology, obstetrics and gynecology.
It's a huge field.
It is. So if you're a learner, a medical expert, or just anyone trying to quickly absorb the most vital information for, say, an upcoming exam or clerkship, you are in the right place.
And our mission today is exactly that. We're using the source material you provided, which is key excerpts from first aid for the obstetrics and gynecology, and we're just going to distill it. We're aiming for the most essential clinical pearls and high-yield facts.
I like that. Going beyond just memorization.
Right. We want to connect the foundational anatomy and physiology to those, high-stakes clinical scenarios you're actually going to see on the wards.
That focus is so important because before we even get to the hard science, success in OBGYN, it seems, really hinges on mastering the non-medical stuff. So let's start right there. Clerkship success.
Yeah, the strategies, the material is very clear on this. It really boils down to professional conduct and a sense of ownership.
Professionalism. That's always number one.
It is. The source is adamant. Always, and I mean always, treat patients and all staff with the utmost respect. And here's the real pearl for the wards. Be nice to the nurses.
That's the universal rule of medicine, isn't it?
It really is. They can make your entire clinical experience so much smoother. They're the frontline experts, they know the patients, and honestly, they can become your greatest asset.
That's just practical advice for life, really. But what about engagement? I know a lot of medical students are, they're afraid to look foolish by asking a dumb question.
But you have to ask questions. There's just an art to it, especially during busy rounds. Timing is key.
So not when the attending is rushing out the door.
Exactly. Use your questions strategically. Often, a student can ask a really good foundational question that actually gives the attending a chance to teach the whole team.
So it's a review for everyone.
It is. It serves as a kind of secondary review for the residents who might feel like they should already know the answer, but, they secretly appreciate the refresher.
Be the catalyst for that teaching moment. I like that. So what about responsibility? What does that look like on an OBGYN rotation?
It means complete patient ownership. You need to know everything about your assigned patients, their history, their labs, imaging, prognosis, everything.
So you're basically the primary source of information for the team.
You should be. The goal is to anticipate what's coming next. You should be the one telling your resident about a new lab value before the attending asks about it. That's what makes a student great.
That proactive approach.
Yes. Be self-propelled, as the text says. Volunteer for things, offer to help with a procedure, maybe even offer to give a quick talk on a topic that's a little uncommon, but not, super rare.
Right, contributing to the team's workload. And speaking of prep, the source has a great study strategy. It says to skim the review book before the rotation even starts.
Yes, just to get the terminology down. Then, when you get a patient, you read the symptom-based topic with that specific patient in your mind.
Which makes it stick.
It makes it stick. And that flows right into your documentation. A good medical student, H&P, should be neat, organized, and probably 2 to 3 pages max.
And if the patient has a super complicated history,
then your summary's gold. If you can generate a crisp, accurate, one-paragraph summary for a patient with a huge chart, the entire team will thank you for it.
Okay, that covers let's call it clinical etiquette. Let's shift now to the foundational science. High-yield anatomy for surgery and delivery. Let's start with blood supply.
Right. So when you enter the pelvis surgically, the main player, the dominant player for blood flow, is the internal iliac artery. You'll also hear it called the hypogastric artery.
And for support, the ligaments must be key.
They are critical. The most important support structure for the uterus is the cardinal ligament. It's also known as the Mackenrot ligament.
And that one's important because it contains
the uterine artery and vein. This makes it a huge landmark during a hysterectomy. You have to know where it is.
And what about the structure supplying the ovary itself?
That would be the infundibulopelvic ligament, or the IP ligament. It connects the ovary to the pelvic wall, and crucially, it carries the ovarian artery and vein.
So that's what you're clamping during an oophorectomy.
That's exactly what you're clamping. And for nerves, you really need to know S2, S3, and S4. They come together to form the pudendal nerve.
Which is key for pain relief during delivery, right? The pudendal block.
Precisely. It's a very common method for pain relief in the second stage of labor.
Okay, let's test that anatomy with a classic clinical case. A 30-year-old woman comes in with acute, localized pain. Says she can barely sit down. On exam, you find a firm, tender, fluctuant mass, maybe 4 by 4 centimeters, right at the 8 o'clock position on her vulva.
Oh, yeah. That is the absolute textbook presentation of a Bartholin's gland abscess.
And those glands are located where again?
Posterolateral to the vaginal opening. When the duct gets blocked, it gets infected, and this is what you see.
And the treatment is pretty straightforward.
The main thing is drainage. You have to get the pus out. So incision and drainage is standard, and often you'll place a little ward catheter to keep it open for a couple of weeks.
Or you can do a marsupialization. Can you just briefly explain what that is for our listeners?
Sure. Marsupialization is a neat little surgical trick. You incise the abscess, drain it, and then you suture the edges of that incision to the skin around it.
Creating a little pouch.
Exactly, like a marsupial's pouch. It creates a small, permanent opening so the duct doesn't just close up and get infected all over again. It's a great long-term solution.
That makes perfect sense. Okay, from anatomy, let's jump to endocrinology. The menstrual cycle, the two main phases.
The cycle can be broken down pretty simply. First, you have the follicular phase. That's roughly days 1 to 14. Its length can be really variable from person to person.
And this is when FSH is the dominant hormone.
Right. Low estrogen allows the pituitary to release FSH, which stimulates the follicles. The granulosa cells in those follicles then start pumping out estradiol.
And the estradiol builds up the uterine lining.
Correct. That's the proliferative phase of the endometrium.
And the second half of the cycle.
That's the luteal phase, which is much more stable in length, usually about 11 to 14 days. After ovulation, the leftover follicle becomes the corpus luteum, and it just secretes massive amounts of progesterone.
So progesterone is the star of the second half.
Absolutely. It dominates. It makes the endometrium super vascular and ready for implantation. That's the secretory phase. And all that progesterone tells the brain to stop releasing FSH and LH.
Okay, great. Shifting gears again. Let's talk pregnancy, diagnosis, and dating. Nagel's rule is still the classic tool, isn't it?
It is, yeah. The formula is simple. You take the last menstrual period, add a year and 7 days, and then subtract 3 months.
But there are some big assumptions baked into that.
2 huge assumptions: that it's a 280-day gestation and that the patient has a regular 28-day cycle, which isn't always the case.
So ultrasound is better.
For accuracy, especially early on, yes. A first trimester ultrasound can date a pregnancy with only about a 4-day margin of error. It's much more precise.
And when we're talking about a patient's history, we use the TPL system.
You have to master this terminology. It's non-negotiable. Gravidity, the G, is total number of pregnancies. Parity, P, is deliveries past 20 weeks.
But TPL gives you the details.
It gives you the critical details. T for term births, P for preterm, A for abortuses, which includes miscarriages, and L for living children.
So give us an example. G3P 2002.
That means 3 total pregnancies. 2 of those were term births, 0 preterm, 0 abortions, and she currently has 2 living children.
That clarity is so vital on the wards. Okay, now for the really amazing part, the physiological changes the maternal body goes through.
Yeah.
What are the big ones?
The change in blood volume is just immense. It increases up to 50% above pre-pregnancy levels.
50%? Wow.
It's a vital adaptation. It's basically a buffer for the blood loss that's expected at delivery. But because of this, you get hemodilution. The average hemoglobin drops to around 12.5.
So if you see a level below 11.
Then you should be suspicious for a true anemia, not just the dilution effect.
And the heart has to work much harder to pump all that extra blood.
It does. Cardiac output starts going up as early as the 5th week. And it's important to remember that a systolic ejection murmur is super common, like 96% of pregnant women have one.
But not all murmurs are okay.
And this is a critical point from the source material. A diastolic murmur is never, ever normal in pregnancy. That needs an immediate workup.
Let's talk about HCG. Its role in early pregnancy is so key.
HCG is the hormone that keeps the corpus luteum alive and producing progesterone. And clinically, the rule of thumb is that the plasma HCG level should double about every 48 hours before 10 weeks.
And if it doesn't?
If it fails to double, that's a really strong indicator that something is wrong. You start thinking about an ectopic pregnancy or a missed abortion.
Got it. Okay, let's move into the labor and delivery suite. High stress, high yield. First step, confirming rupture of membranes, or ROM.
Right. The patient's history is about 90% accurate, but you have to confirm it. There are 2 key tests.
The first one is ferning.
Yes, ferning. You put a drop of the fluid on a slide, let it dry, and the salt in it crystallizes into this beautiful microscopic fern pattern. That's up to 98% specific.
And the other is the nitrazine paper test.
Correct. Amniotic fluid is alkaline, so it turns the yellow nitrazine paper blue, but you have to know the false positives.
Like what?
Blood, semen, even a trichomonas infection can all make the vaginal pH more alkaline and give you a false blue color.
Okay, so once labor is underway, the single most important indicator of how the baby is doing is the fetal heart rate tracing.
Without a doubt, the normal baseline is between 110 and 160 beats per minute.
And what makes the tracing reassuring?
The definition is very specific. You want to see 2 or more accelerations. That's a jump of at least 15 beats above baseline for at least 15 seconds, all within a 20-minute window.
And that tells you.
It tells you the baby's central nervous system and cardiovascular system are intact and working well. It's a great sign.
Now, contrast that with the bad sign, like late decelerations. What do you do if you see those?
You have to act immediately. This suggests the baby isn't getting enough oxygen. So, first, you change the mother's position, usually to her left side, to get pressure off the vena cava.
Then oxygen.
Oxygen by face mask. Then, stop any oxytocin that's running. And finally, give her an IV fluid bolus. It's a sequence of 4 crucial steps.
Okay, another emergency. Shoulder dystocia. The head comes out, but then it pulls back in. The turtle sign.
A true obstetric emergency. You have a very short window to act. The first and usually most effective maneuver is McRoberts.
That's where you flex the mother's thighs way back against her abdomen.
Exactly. It just slightly rotates the pelvis and flattens the sacrum, which often gives you just enough room, if that doesn't work.
Then what?
Then you apply suprapubic pressure from the outside, trying to push the baby's shoulder down and under the pubic bone. And if that fails, you might have to try internal maneuvers like the Woods corkscrew.
Okay, wrapping up delivery. Let's talk expected blood loss and signs of placental separation.
So for a standard vaginal delivery, you expect around 500 cc's of blood loss. For a C-section, it's about double that, so 1,000 cc.
And before you pull on the cord, you need to see signs that the placenta is ready to come out.
Yes. There are 3 classic signs: a sudden gush of blood, the umbilical cord getting longer at the opening, and the top of the uterus, the fundus, rising up and feeling firm.
Finally, postpartum care. What's the normal progression of lochia, the vaginal discharge?
It follows a predictable pattern. First, lochia rubra, which is red and bloody for the first few days. Then lochia serosa, which is paler and more watery for about a week. And finally, lochia alba, which is whitish yellow.
And what's the one postpartum complication we absolutely have to remember?
Postpartum hemorrhage, or PPH. It is still the most common cause of maternal death in the Western world. You have to be vigilant.
And there's a mnemonic for the causes, right? The 4 T's.
The 4 T's. Tona, boggy, atonic uterus, which is the most common cause. Then trauma from lacerations. Tissue, meaning retained placenta. And thrombin, a clotting problem.
And one final clinical pearl about contraception for breastfeeding moms.
Yes, this comes up all the time. Combined oral contraceptives, the ones with estrogen, can decrease breast milk supply, so you want to avoid those.
So what's the preferred option?
A progestin-only contraceptive, something like the depot shot or the mini pill, they provide great birth control without really affecting milk volume.
This has been an incredibly rapid but really thorough synthesis of some huge concepts. So, to lock it all in, let's finish with the clinical review question from the source material. This one is about hypertensive diseases in pregnancy.
A perfect way to test everything. Okay, here's the scenario. A 37-week G2P1 woman comes to the labor unit. She has a severe headache and is seeing black spots in her vision. Her blood pressure is 165/95, and a urine dipstick shows 4+ protein.
Okay, so you have late gestational age, severe range blood pressure, massive proteinuria, and end organ symptoms with the headache and the vision changes.
The scotomas, yes.
This has to be severe preeclampsia near term.
That is exactly the diagnosis. So what's the next best step in management?
With severe features, the definitive treatment is delivery. So you need to deliver the baby immediately to protect the mother. And you'd give magnesium sulfate for seizure prophylaxis.
Perfect. That's precisely right. The presence of any severe features means you move to delivery and you start seizure prophylaxis with magnesium sulfate.
That brings our deep dive to a close. We've covered a ton, from clinical etiquette to critical care. As you process all these high-yield facts, here's a final thought to consider. When we get informed consent for a procedure, we focus a lot on risks and benefits. But remember those 3 essential conditions. The consent has to be voluntary, the information has to be comprehensive, and the patient has to be competent. Think about how often those pillars might be challenged in the fast-paced, high-stress world of the delivery room.